You found Stay Off My Operating Table with Dr. Philip Ovadia. Today we are joined by someone who's in a part of the healthcare world that doesn't get a lot of press, at least not that I've ever been able to see, and yet is something that all of us have a high likelihood of being a part of at some point in the future. Phil, bring our guest into the conversation.
Yeah, definitely. Excited to have Cheryl Field with us today. Cheryl and I spoke together at a conference a while back. And like you said, she kind of covers an area of the healthcare field that doesn't get a lot of attention necessarily, but probably is something that most of us should be paying attention to. And this, kind of falls under the category ultimately of helping people understand the system and how not to get screwed by the system. So excited to have Cheryl on. I'll give a little bit of her background, but then I'm going to let her fill in the details. She is a nurse and has an extensive history in nursing, and then has focused on senior care and understanding, again, that aspect of the healthcare system, which I think is important to all of us. So, Cheryl, with that, why don't you introduce yourself a little better to our audience? Maybe talk about your background and then how you got interested in this aspect of the healthcare system, and then we'll get into some of the details.
Yeah, thank you so much for having me. As you said, my name is Cheryl Field. I'm a master's prepared nurse, actually a bit of a misfit nurse. I applied to university thinking I would go off to medical school, really struggled in my big, huge class of chemistry and fell into nursing and have never looked back. So it's really been a wonderful space for me to apply my strengths and to apply my passions and really just to grow as a human, as a professional. I've been 35, almost 36 years, and my whole career has been in senior care. So like you said, Jack, it's not a part of the healthcare spectrum that certainly doesn't get good press. It may get some negative press, but it really doesn't get good press. And it's just, there's so much amazing work that is done for seniors by incredibly dedicated providers in that space and in that sector. So, and I worked in direct care the first half of my career, and then I moved into what we call clinical informatics. So really work on the software side, supporting those operators, those nurses who come to work in a nursing home or assisted living or independent living. Maybe they're talking with health plans using technology and working for companies that, figure out systems that make that easier. And that's been my professional experience with healthcare. And, my mission to empower caregivers has really come from being a caregiver. And I came into the caregiver space with my mother, my father, my aunt, my mother-in-law, and I saw huge gaps in what I knew should be happening and what was happening, the staffing crisis, the procedural crises, the transition to digitization. It's really hard in healthcare to get older and move from specialist to primary to back home and have anything be kept consistent. So the book that I ultimately wrote was called Prepared, a Healthcare Guide for Aging Adults. And I wrote that as a result of figuring out how I had to show up differently in the sector. Couldn't be yelling and screaming or angry all the time. I needed a system. And so I designed a system of questions and things to bring and what to expect that really helps that unexperienced consumer become an expert and know what to expect when they're moving through the health system, being able to be in control and advocate as you move through the health system. So that's a lot about me. I still work full time in artificial intelligence. In fact, I'm deep into machine learning models and predicting outcomes in older Americans that we don't want to happen, like falling down or going back to the hospital. And since I met you in the fall, and really my head was just spinning with the data and the statistics that you placed up on the wall. And um, since then, it's really been I've been integrating what I've learned from you into my work with caregivers, and it's just so exciting to see the empowerment and the impact on their own health and the health of their loved ones. So yeah, it's this metabolic health and the awareness of it. Again, I have a master's degree in nursing. No one talks to you about anything, at least in my genre, than you know, healthy grains and low fats. And I wasn't new to it. I'm going to be honest and tell you, I was dipping my urine for ketones at 9 years old. I was the third child in a family of very heavy women, and my mom was going to go do, I don't know, she might have been on a liquid diet. Somehow we were all going on a diet this summer. I was overweight in third grade, and so we all went on keto. And so I knew what ketosis was at 9, and I lost weight. And then I, gained it back in fifth and sixth grade. And, the rumor was that I had ruined my metabolism by using keto at such a young age. And so I went to nursing school, and they said, well, just, you have to just go on low fat and 5 or 6 meals a day and whole wheat and grains. And so I, really raised my family like this, but I could never get the weight off, could never, crack that code up and down. And really just since, and a couple of times in my life where I've gone on the adventure of really attempting to get that weight off, scientifically, I observed that my body really couldn't lose any weight if I was consuming more than 20% carbs. And, coaches would say, oh, that's too low. And I'm like, you don't understand. At 25%, I will stay the same. At 30%, I will gain. At 20%, I might lose a half a pound if I'm perfect, for a week. And I just said, oh, I must be insulin resistant. It must be because I'm middle age, I'm perimenopausal. This is what happens when you get older. So I will
I'm
say,
doing the
having
math.
met you and read your book, there's an optimism that maybe my body's not broken. I just haven't been fueling it properly.
Ooh, that's so good. I was just doing the math. If you're doing 1,600 calories a day, 20% is 325 calories. Am I doing that right? Is 325?
Yeah, so it's going to
Uh,
be about 80 grams of carbs
yeah,
there to get to that.
yeah, that's not even really particularly low. Anyway, sorry.
Yeah,
I
it's
eat,
low
actually, I eat
compared.
lower than that now. It's crazy.
Yeah.
Just-
So, yeah, let's talk about maybe before we get back to the metabolic health stuff. Let's talk about, senior care, elder care. It gets called lots of different things. But I guess it will be good to hear maybe some of the stats from you, but it shouldn't surprise anyone, right? That this is a big part of our healthcare system, right? People get older, and older people require more healthcare is the general trend. So maybe talk a little bit about what people may not realize, let's say, about elder care, about the senior care system, and some of the ways, some of the things you talk about in your book, Prepared, to help people prepare for that, because we're all going to get there.
That's the only thing. That's why I say, with age comes change, and 100% of us will experience a sudden change in health. That's just for certain. Whether it's one or the last one, but 100% of us will have a sudden, some kind of sudden change in health. So I think what's really interesting about the senior space, and I'll define that by saying Americans, when we reach the age of 65, in the United States, we officially have an opportunity to get health insurance for the first time from the federal government under the Medicare program. And there's a lot of confusion around that. People think they can get it at 62 when Social Security begins. It's so interesting. Our whole lives when we go to work, our insurance is offered to us through our employer. And they've really done the research. They've gone out and they've looked at the health plans and chosen a vendor, and within that vendor they may have 3 or 4 options for us. And even during that open enrollment period, I know myself, I spend quite a bit of time trying to figure out between these 3 or 4 options, which one will I choose? but our employer's done the hard work of bringing in one vendor. Now, at the age of 65, without education, without information, our seniors are suddenly exposed to the market. They're given a choice of Medicare, traditional Medicare that we think of, and of course, the compelling new player that's really grown over the last 15 years, the managed Medicare contracts, which are offered through traditional insurance companies. 52% of Americans today over the age of 65 have chosen those managed Medicare programs, but many providers like yourself are quite frustrated with the cost savings strategies that those programs will bring into that senior care space. So, as so few people realize this chaos that's about to be ensued upon you as you reach 65, and you're choosing a health plan that I think is really essential because they're your partner in your health. They're paying for services. You're going to find providers that align with, what you need in your life. And, so few seniors realize that there's a tension in the marketplace between, what their doctor will accept for an insurance and not. They don't realize these contracts, can easily be shut down if they're not profitable. And so you might choose a health plan in a managed care plan that's contracted in your county. And then you get a notice, 90 days out that they're not going to renew that contract. But oh, by the way, the doctors that you like won't accept the new plan. And so there's a lot of chaos around just figuring out who am I partnering with to cover these services. Not to mention, as you brought into the conversation, just, hey, the beauty of being 65 is you're more than likely going to have some kind of chronic illness that you've, crept up over the years. It didn't get you when you're 30. You didn't have a heart attack at 40. You didn't do these things at 50. But now you're 65 years old and you may be out with some high blood pressure or high cholesterol that, you find yourself on multiple medications and being treated by multiple specialists in a system where, one, the technology is not connected, so information doesn't move easily amongst those specialists, and two, the health plans don't want to pay for expensive care.
Yeah, it's interesting the terminology you used, right? That talking about the insurance companies as your partner. And the unfortunate reality is that it's not an equal partnership, right? They are going to largely dictate, where you can get care, what type of care you can get, and in the end, they have the veto power, right? Your doctor might recommend something and they can say, we're not paying for it, right? And this is one of the sort of subtle tricks, right, of medicine, right? They don't say you can't have that done. They just say we're not paying for it, right? If you want to have it done, you got to pay for it, and that becomes a whole nother can of worms. So as people are evaluating those choices, what do you think some of the key considerations should be as they're trying to figure out, what type of plan and then which company to go with and all the choices that go into this?
Yeah, it's a fantastic question. I actually do a lot of teaching strategic planning on, for 63 and 64-year-olds. I really like people to actually make that decision in their 63rd to 64th year. So they have year 64 to go look into the marketplace instead of trying to rush themselves. So I have a kind of a little decision tree that I like to think through, and the first is, are you active? Are you moving? Are you all over the place? Are you traveling? Because you need a plan that goes with you. And many of the managed care plans are, in fact, limited to a local network, and they want you to stay in that network for care. That's how they can contain cost. The other thing I, ask people about is their love affair with their doctors. Do you have a lot of specialists? And would you do anything to keep that specialist? And there are some people who are like, oh my gosh, I will pay whatever it is, and I have the financial ability to do that. Not every senior does. So if you can afford it and you have specialists and if you really hate getting things referred or authorized, traditional Medicare really is a fee for service program. It's quite simple. You come in with your card and the doctor provides a service and they get paid a fee. And it's unlimited. We can do lots and lots of it. And of course, it feels a bit unsustainable if we're spending more than we need to on care, which is why we have even the idea of managed care and some cost containment programs. But there are some folks who hate the idea of getting a referral, can afford to stay on traditional Medicare, want that freedom and flexibility, have some specialists that they're absolutely committed to and feel they really trust. And that's just so important. And, that may mean that they choose to stay on a traditional Medicare, even though at the end of the day, they may spend more money for that same health outcome. They feel more control over their own health outcomes than what you may feel in a managed care situation, to your point, where the insurance partner, payer, will say to you, it's either not in formulary, we're not willing to pay for it, and that physician is now out of network. And this has happened here, I'm in the Northeast in New Hampshire, and we've had some hospitals where after 20 years of a contract with a health plan, they didn't renew the contract. And so, again, local consumers who felt trust with their hospital and their physician were really facing being cared for in another institution. And you know how that feels. It feels awful. You hate to change. My husband still drives nearly an hour to where we used to live because he likes that hospital and he trusts his doctor. And that we take a lot of inconveniences for that. So, I think that our senior population, unfortunately, the healthcare system's chaotic at best. And I think it's really hard to navigate, which is really why I wrote the book, because I was having a hard time navigating and I was an expert and knew what I was doing. How can, a son, a daughter whose parent has a sudden change in health and they're going to show up and they're going to advocate, but their background is engineering, right? Or marketing, or they're a teacher. They've never experienced this massive healthcare system and they don't know where to begin. And yet they get a phone call and, oh, they got to go. They got to begin. And so that's really why I wrote the book, because I wanted someone to pick it up and turn to that page, be like, oh, I'm on page 13, headed to the emergency room, and here's the 10 things I need to bring and the 10 questions I need to ask. And Cheryl's going to guide me through this emotional, traumatic experience. And I break it apart. If your loved one chose Medicare, this is what's going to happen. If they chose managed care, this is what's going to happen. And these are the names and the titles of the people you're going to meet along the way. Because they really are managed. They're two fiscally different philosophical systems. Fee for service is not the same as cost containment. We don't operate the same. That's quite different.
I don't even know where to begin. I would love to hear examples. Like, so you're off to the emergency room. S- give us a little preview there of the book. I ask this because 3.5 years ago I had that particular experience, and I largely felt like the trip was a complete waste of time. But I got a 5-figure bill out of it anyway. So
Yeah. So, and let me just share that I was so blessed to live with my husband's aunt. We lived multi-generationally for 17 years. We built a house with the intention of raising our children in a multi-generational home. We built an in-law apartment, and right across the street was a mother-in-law. So we were sandwiched between, my mother-in-law and my aunt-in-law. In fact, she's on the cover of the book. You can see it behind me, prepared. That's actually her picture taken in a rehab on a day when she was feeling particularly down, and my daughter had painted her this really lovely little, watercolor that says, half full, just to remind her that, you're only here for a short time and then you're coming home, and keep up your spirits. And when I finally published the book and I was really working with the publisher on different covers, I'm like, no, I think this one picture on my phone, because that's the kind of mom I am, I'm always on my phone taking pictures. I think this picture is really going to capture the essence of what it means to be a senior in the United States. You know, you don't have a perm, your hair is straight, and you're a little down in the dumps, and you need to be lifted up, and families visit. And this was one of those moments. So, Jack, I learned these things by not being prepared. The first time she fell in the middle of the night and we had to call an ambulance, and I was fine while she got into the ambulance, and then they were going, and I was like, oh my God, wait, what do I need to bring? She's gone, but the little wallet, the insurance card, how about her glasses? Right? She's not going to be able to see and sign paperwork. She went off without her glasses, and little things like that, the dentures, the extra stuff, the phone charger. And I tell people, if you're sitting in the emergency room for a long time, it's a really good sign, because the people dying get pulled in quickly. So hang out and be patient, and don't worry if it's a long time before they get to you. That's a good sign.
That's a
Um,
good sign.
and people don't understand. I actually was giving I do a lot of live speaking and conversations to seniors. So I was at our housing authority last week, and I do a talk called, 5 tips to stay out of the hospital. If we want seniors to stay out of the hospital, frankly, Jack, I got to keep them out of the emergency room, because there's a bias. You see an old person coming in to the ER, they are, 3 times more likely to be admitted than their younger counterparts. It's just like, send them upstairs. There's too much going on here, right? You're shaking your head. And so I tell them, look, if you want to stay out of the hospital, got to stay out of the emergency room. And we talk about good nutrition and hydration and getting rid of the carpets and movement, but also paying attention to changes and not putting them off, you know, putting them off. So I was giving a talk with this group, and, just sharing with them some insights around, how they might, stay out of the emergency room. And this gentleman said, you know, they don't really care about me. I come into the emergency room, and the very first thing they ask me for is my insurance card. They just want to get paid.
Yep.
And I said, well, I'm going to be honest with you. They actually have to do 2 different processes, depending if you're Medicare or managed care. And even within managed care, there are different forms, different requirements that the individual payers require of them to, in fact, get paid. So I said, it's not that they don't care, but from the very moment you enter, they have to do the right thing by you, and they have to communicate with your payer, or they don't get paid for the care, and your care doesn't get coordinated as effectively. So I think these awarenesses that I share in my book, it changes the way people think about what they receive when they do get to the emergency room. Instead of walking in sarcastic and cynical, they can be like, oh, hey, I know that you want to get as quickly connected to my payer as possible, so you get the right case manager and my care gets coordinated. That's a good thing. I'm happy to give you my card. And so those are, just some examples of what I place in the book. And I do that for each of the transitions. I think we probably have more experience with emergency rooms than we do being admitted, and then being admitted and needing a rehab stay. And that going to rehabilitation, which is going to happen in a nursing home, that meets with a ton of resistance. Nobody on this call, except for me, I'm probably more open to it, really wants to go to a nursing home and hang out for a short period of time. But I've kind of joked about it my whole career. I'm like, I can't wait to get in bed with that call bell.
Huh.
I'm gonna have a good time that day. But those transitions are hard. And so I give people the mindset to think through that rehab stay is like an investment in you and your health, and how to leverage it for good and not fight it, each step of the way when you're just not ready to go home without, assistance.
It's interesting, Art. Most of the time, what we're talking about on this show can can be summarized as, here's how to stay out of the hospital. I mean, the name of the show is Stay Off My Operating Table. So, as far as
No,
I know, you have to be in the hospital to end up on Phil's operating table. Correct me if I'm wrong.
No kitchen surgeries here.
no, you're not doing a drive-through yet?
Oh,
Not quite. maybe as the AI and the robots will get us there one day. But yeah, it's certainly, like you said, we're essentially trying to keep people out of the hospital, off the operating table, and that starts with trying to stay out of the ER largely, because that's the way that the vast majority of people get into the hospital.
So it sounds like your focus let's is on those folks who, for whatever reason, either because they haven't followed Phil's advice or they haven't, something happened anyway, and they end up heading to the ER as a senior. Here's the things that you really would be better off knowing now before it happens than after, and you're trying to figure it all out.
Exactly
Have I
right.
got have I got that
Yeah,
right?
you've got it right. And then, just guiding them. And many times it's their families, it's both the senior and the family. You're guiding them step by step. And in those moments, they're better served step by step because they are overwhelmed with the emotion and the chaos at the time to think through the hospital stay and be thinking about rehab is sometimes too much. They just got to first get through that hospital stay. Maybe it's a fall with a fracture, maybe it's not a cardiac issue. And so, they want to take it sort of one step at a time. And from a architecture perspective, I designed the book that way so that you could go from one level of care to the next and know what steps and tips and questions to ask as you move through. And a lot of the community work that I do are with seniors or their adult children caregivers. And I'm fascinated by how many adult children are living with and caring for their parents, like full time. And I'm involved in groups on Facebook, and there's thousands of people who are really just all in for this chapter in their parents' life. And since really coming to understand metabolic health, really focusing in, like you said, the 7 principles you teach in your book. When caregivers say to me, I'm overwhelmed, I'm burnt out, I'm emotional, I don't know what to do, I actually think it's quite empowering to say, okay, you know what? Here's how you're gonna take care of yourself. You throw away all your processed food and you eat whole foods, and just do that for a week. And a week later when we get on a coaching call, well, they actually feel better. And then their loved one is eating better. And I don't actually say to throw everything away. I like you suggest in the book, like making small substitutions, but I think they feel empowered because there's something they can try. They can't make their loved one go away. They can't make their illness, go away. They can't stop their job and the kids and the everyone has to eat. But what they feed them can be whole foods. And I think they see that their own blood sugar stabilizes. They have less mood swings, less irritability, less crying, less fatigue. They start to sleep a little better. And that becomes really quite empowering. Next I talk to them about movement and putting on some music for their loved one and just moving. And, simple, small movement can become a bigger movement. And these are really helpful conversations. We get to hydration. We talk about, these are ways to stay out of the hospital. Got to keep them hydrated, drinking water versus the soda. We talk about different flavors and keeping it around, and that water, it just makes us do more movement as we head to the restroom, in between. So these are free, not that they're not expensive, because they do feel the economic impact of eating healthier, but they also find themselves eating less. And so their total grocery spend over time actually comes down when they're not buying the cereal and chips and things that are quite expensive, but they're investing more in the whole foods. So I think that this conversation's really essential in senior care. It's rounding out what I can offer to families that come to me for counsel. And it's not going to make their loved one any younger. But in many cases, and I think you were, sharing an opening story of how quality of life can really improve. And, who knows where there's really no bounds to that, right? Someone who's been wheelchair level for a long time is suddenly standing. And those stories are not going to be unique. I think for caregivers, for providers of care who really focus on metabolic health and how we fuel ourselves even in later stages in life. And I think that was one of the questions I asked you was like, oh my gosh, how does this apply to the skilled nursing homes who are still feeding off a food pyramid? And that just outraged me. I was like, oh my gosh, we're feeding them all wrong. How do we change that? Like, how do we change those regulations and step away from a food pyramid in an institution where, we need to up the protein and up the fats for people in a cost-constrained environment? It's challenging.
Yeah, we've had Hal Cranmer on this show, who runs senior care facilities and is having amazing results. And we see the examples all the time. And even within my practice, we have many people in this age category who are doing great and seeing these improvements. And I think that's always going to be your best preparation, right? Is make yourself healthier, so that hopefully you can largely avoid a lot of these issues that unfortunately so many of our seniors get into with the multiple medical problems. Maybe talk about, so besides the choice of, your insurance plan, what are some other kind of big issues that people should be thinking about, but don't think about, or don't know to think about? What are some of the other big concepts that people should be paying attention to, whether they themselves are in this age group or approaching this age group, or if it's someone younger, maybe thinking for their parents or other loved ones?
Yeah, those are great, really great questions. And there's two important topics that I like to speak on. And the first one is being very intentional about how do I stay in my own home for as long as I can? And, by and large, this is what I hear people saying. They really want to live independently in their own home. It's not to say they may not have, 55 plus communities are popping up all over, and they may like living in that 55 plus community, but they still feel very independent in their own home. And so if you want to do that, now I'm talking to you all about health promotion. It's, everything we've talked about, from a nutrition, a movement, a hydration, and an environmental assessment. Looking at the home, I tell people decorate the walls, not the floors, get rid of the rugs, installing the grab bars, being really risk aversive and intentional about that, saying, you know what, climbing on that ladder is kind of risky. That I won't do that. I'll take the stairs 4 times a day, keep up my strength, keep up my movement, but I don't need to take a risk and clean the gutters. We'll write a check. We'll have someone come in and do that. And being very intentional about that. Also, anticipating a change in your social interactions and organizing things like a game night at your place, joining clubs, making sure that you're going out to things and bringing things in, and filling that gap. I actually encourage people to be very selective and find younger friends. If all your friends are older and they're going to pass and you're going to feel that grief and that sadness, make it a goal, kind of like a metric. In marketing, we say we need 100 leads a week. Make it a goal to meet a new person every month and add a new friend. And, I have this conversation with my dad. He's 90 and a half. He's lost his life friends. It's been really hard for him. And even when I've suggested that he meets someone new, he says, well, I don't think I'm going to have enough time to develop a good relationship. Maybe I don't have another 5-year friendship with someone new. Well, why is that the standard, Dad? The standard is engagement. The standard is conversation. And we need to keep ourselves cognitively, socially, psychosocially, connected. Because what I see people do as they age, and this will bring me to my second point, which is a mindset shift. We begin to age. We need assistance with things. We either stop doing them because we have a mindset that we do not want a stranger in our home, or we start subletting them. We don't go to the grocery store anymore. We push a button, we use an app, we order food, it comes to the home. It appears to be a good thing, when in fact it's less movement, less weight bearing, less resistance. I would much rather you hire a companion and go to the grocery store with your companion and continue the activity. But that means a mindset shift in welcoming a stranger into your own home. And so many times I hear older Americans say, I want to live in my own home and I don't want any strangers in my house. And I'm here to tell you, you can choose to live in your own home. You'll probably need strangers coming in, providing care, and you're probably going to pay for that. And if you don't make those kind of choices, ultimately, you may end up living in an institution. And I'm going to tell you, in that institution, you will be cared for by strangers and you will probably pay for that care. So if we switch our mindsets and we're intentional earlier in our aging years, I think we have more opportunity to stay in our own homes, but expand our communities and bring people in and out so that we can truly create that community that we want in those walls we've defined as home.
Yeah, I mean, it sounds like so many other things in life, right? That if you just wish for outcomes, that's usually not a great plan, right? You got to be intentional. You got to decide what's important to you. You got to prioritize these things, and then make the appropriate arrangements and preparations, and do the things in your life that are going to actually get you the outcomes you want, instead of just sort of hoping that they happen.
Yeah, that is a great word. I'll say one thing as well while I'm on this sort of advanced directive soapbox, is that I want people to think about their advanced directives. It's really in the first part of my book. Being prepared for a sudden change in health goes beyond advanced directives. And includes things like your medications and your past surgeries and your histories, but also how you move, what your daily routine is like, what devices do you use? If we could get everyone to think about, and it's uncomfortable, so I know why we don't like to do it, but we really need to think about, what do I want for my life in the event of incapacitation? I could sit here and tell you, hey, you know what, if tomorrow is my day and I go quick, in front of a car or quick in front of a train, okay, it's quick.
Yeah.
But being incapacitated, ooh, that's a lot harder to think about. Living 15 years in a nursing home on, a feeding tube or artificial this or artificial that, without an advanced directive, a sudden change in health means that the state laws will regulate what you receive for medical care, and it may be everything. Without an advanced directive, you haven't communicated what you really want to your loved ones, and they can't advocate for you. So when people are telling me they feel very unprepared, I encourage them to do two things. Get their advanced directive in place. It's not hard. It's uncomfortable for 30 minutes to think about it. Then you sign it, you seal it, you put it away, and you feel a relief. The second thing that's really helpful for adult children of their parents is, to get a dual power of attorney for health and finance. In the unlikely event or likely event, something happens, and they can then speak for them, while they're, incapacitated. And so if you're not prepared, at least those two things really give you better control over situations should it actually arise.
Great.
These are things I haven't thought about.
Yeah, great
And
advice.
I don't want to.
No, you're right, Jack. And I was selling copies of my book at a craft fair. And I thought, well, this is great. And my demographic is right there. There were tons of seniors, but you know what they said to me? I don't want to think about this. but their adult children were like, Mom, come back, come back. We need this book. So I think you're right. It is uncomfortable to think about, but it is a relief when you have it in place. And it's also, maybe what parents haven't thought about, what seniors haven't thought about is the uncertainty is stressful for your children. To sit down with your children and say, hey, this is what I would like. This is what I don't want. This is what I would like. It relieves that uncertainty for your children. And sometimes you can use that lever. Parents will do anything for their kids. So you can use that lever to help them move through these uncomfortable situations and uncomfortable conversations to kind of get this work done.
This is kind of like putting together your trust.
It
for
is, but I
them.
don't think we should wait until we're thinking about a trust. Honestly, I think that in this country, at age 18, if you want to renew, or 21, whatever, when you go to renew your driver's license after your 21st birthday, I think you should have a current advance directive on file, even if for the first 10 years or however many years somebody is saying, do everything, do everything, do everything. It would get us in the habit of thinking about incapacitation. And it would give people an opportunity to be like, you know what? I've experienced that. I don't want that for myself. Let me write that down. Let me say right now, I would not want to be, with brain damage and a feeding tube for the next 30 years. Let me say that today at 25 or 30. But we don't require it. And so we don't, to your point, Jack, we don't think about it from 21 when your parents, wait, is it 18 or 21 when your parents can no longer speak for you? You don't have an advance directive, you don't have an agent. I think it's 18. Until we start thinking about a trust in our 50s or 60s. We've got chunks of the population without advance directives. No instruction, do everything, not prepared.
I don't even know how you follow up on that.
I'm gonna follow it up with a little transition, and sort of framing as knowing what you know about the system as is. And we seem to be now, and again, we're recording this in February. We're on the precipice of a lot of changes coming to healthcare. We have new administration, and it certainly seems to be one of their focuses. And what do you think, are some of the issues, right, that most urgently need to be addressed? And then maybe talk about, what are some solutions that you would like to see happen. But more so, I just want to hear, like, what aspects of healthcare do you think, are most problematic and need to be addressed as we're trying to reform the healthcare system?
Well, that is a very big question. My brain is thinking systematically around, where do we stop the bleeding? And that's really a metaphor for the healthcare system. And I think that, I do think that for me, if we can get back to basics for humans, and that, I think for me, that's taking apart some of the dependency we have on pharma, and every in my experience, when I was going through changes in health in my own life, which were probably perimenopause, but came off as rapid weight gain without a change in diet or exercise at a time when my mother-in-law and my mother were both very ill, and I was dealing with 3 children, a full-time job, and 2 sick family members that I was trying to advocate through the healthcare system. And I presented with this, I was gaining 3 pounds a week. I gained, 30 pounds over a short 2 or 3 month period of time. And I said to my physician, something has got to be wrong. And her first thought was depression. And, just to give me an antidepressant, I said, I'm the happiest depressed person I've known. Like I would have a nervous breakdown and not even know it. I'm so upbeat and optimistic. I'm not convinced this is depression. And, go see an endocrinologist. And so I knew something was wrong, but what I was getting from the system was prescriptions and prescriptions and prescriptions. And I think that's where that's where the wheel has to stop. And whether that sits in education, because you and I have both, talked about this as master's prepared people and lifelong learners, how is it we don't know, or we didn't know until we knew about these connections with metabolic health and health, and that what we really think about for some of these chronic illnesses, the root cause was wrong. And we've got to get back to, if we can just feed ourselves, get the toxins out and reduce the inflammation, a whole host of chronic illness really goes away, and we don't need those prescriptions. So, I think changes in the education have to happen and be recognized. The science has to be recognized. I also think that fundamentally, when we seek care, we want more than a prescription. We want an approach that's, really from a functional health perspective. And then I think that, again, who are we listening to? And, that those physicians who are getting results without prescriptions, but are looking at diet, and not putting kids on, Wegovy and these drugs. Like, here's an idea, get them off the sugar, get them off the toxins, and get them moving. And then that child is going to lower their insulin and actually have a healthier result. But the system is so comfortable just with a prescription pad. I feel like we have to break those chains and those cycles, because that's very cyclical. I'm not sure how to get, I shared with Jack in the opening comments that, I came home from meeting you. My eyes were so wide open, I couldn't get out of your book. My 28-year-old daughter was reading Casey Means' book on good energy. And so we're just like humming, oh my gosh, and we're getting our grass-fed beef and butters in the house, and we've, removed the toxins. I haven't had a soda since I talked with you, or almost anything processed. It's just been like, oh yeah, I don't do that anymore. But my husband, who's, really holding fast to, wait a minute, you've been telling me I can't eat this my whole life. The steak was bad, butter was bad, da, da, da. And now he's the guy on the high blood pressure pill and the statin. I'm like, listen, get rid of your chips, get rid of your soda, get rid of this, eat this, this, and this, so you can drop your drugs. He's like, yeah, no, I don't know if I believe that. How is this science? That's really the question. I think the most opposition is, how do we know that this segment of time, that this science is right? I said, well, the data is showing us that the other science was wrong. But I'm sure you hear that objection. I'd love to hear your response to that. Like, how do we get those dads in the world to, to try it?
Yeah, exactly. And it's kind of a house of cards, right? Because they falsely put forth this narrative as fact, right? This hypothesis was presented as fact without ever having the evidence for it. And now you're exactly right. We're in a situation where we're being kind of asked to disprove something that was never proven in the first place, right? It was just accepted. And yeah, I understand the skepticism. Like, if this, if such a deeply entrenched idea was wrong, how do we know the other thing is right, type of thing. So it is difficult to deal with, but I certainly agree with your sentiment, right? Reducing our reliance on pharmaceuticals is going to go a huge way in really reforming not only the healthcare system, but meaningfully improving people's health. Which is really, what our focus should be on. One of the other things I talk about is just how, we've lost track of the people within the healthcare system, right? The healthcare system has become about serving everyone except the patients and the doctors, quite honestly. And that's what we need to get back at, the center of all of this. And I think that will lead us to a lot of good things. Maybe in a few minutes we have left, you mentioned at the beginning, sort of, I guess what we'll say is your day job, right? Looking at AI and large language models and how they're starting to impact the healthcare system. And I think it would be great to kind of hear your perspective on this. How should we be thinking about AI and healthcare these days?
It's such an exciting space, and I'll tell you, we shouldn't be afraid of AI, but I'm going to put that in some air quotes. We shouldn't be afraid of responsible augmented intelligence. And so in healthcare, when we leverage these technologies, we're going to do so thinking of them as a tool, acknowledging that they're a tool in the hand of a clinician, a physician, not to be running as agents independent and on their own. So in the senior care space, where we have over the last 20 years actually digitized and standardized lots of data. And now, even in the healthcare, in the hospital sector, we have digitization of information, but you might still write a progress note that looks a little unstructured. And we have these technologies and algorithm on the machine learning side that can look at that standard data. We have large language models and some smaller language models that can look at patterns of language and that unstructured language. I think we can bring some efficiency to the clinician. I've been working in analytics over 25 years where to simplify that, we're going to go out and gather data. We're going to bring it in, going to normalize it, try to make a little sense about it, tell you if it's above or below a certain threshold. Then you as a clinician, you decide, well, how do I fit this into the care plan for this human? I think AI is really exciting in the efficiencies that it can bring to the clinician as a tool. But again, we have to do that responsibly, meaning we have to understand the data that we train the algorithms on. Every set of data has bias. And
Uh,
once we know that data bias, we can be transparent about it. We can say, hey, this model's really good at making this prediction. When we study nursing homes in the United States, we're about 85% widowed white women. So the data has a bias, but it works well in the nursing home space where those, people still come in. We can understand the difference in our ability to predict a certain outcome based on some race or based on some other socio-demographics. But to be transparent about that, to use clinicians in both the design, the discovery, and the testing of models is really essential. So if an operator, an administrator, or salesperson comes to your hospital and says, hey, we want to, introduce this really cool machine that's got AI built into it, we need every clinician asking questions around, well, what was the data? How much did you have? What did you train it on? Were there clinicians involved in the development? Is it right? Because we have a risk. We have to look at the risk of that prediction being wrong. And again, that's why they're not going to ever operate independent of, but along in the hands of clinicians. And we have to be able to be very transparent and make that output of a model, which let me be really clear, it's math on top of math on top of math. It's like unbelievable math. We have to make that outcome interpretable to a human and to a clinician. And so
wait. Did you hear that, Phil? To humans and clinicians.
well, because the clinician has to explain it to the patient. If Phil's going to say, listen, you have a high probability of having this event in the next 6 months, and because of that, we recommend this treatment, he has to be able to explain that predictive model, and it has to be transparent. And, I'm going to say, well, what percent? What percent of people have that bad outcome, and what percent have a good outcome if they have this procedure? Just like we do today with any other types of data, but it's all historical data. We're counting things that already occurred. With machine learning, we're going to use those patterns. We're going to train on historical patterns. We're going to look at real-time data and make a prediction about the future based on pattern recognition. And it can be really fine-tuned. So, congestive heart failure is not the same 5 minutes into your diagnosis as it is 10 years into your diagnosis at 50 versus 80 with 3 drugs, with the 10 drugs. Machines can see these trillions of patterns and really help us titrate, risk. So I think it's exciting, but I want clinicians asking questions. I want them involved. I want us to be responsible, transparent. The name of the game is going to be to build trust with the clinical users, give them opportunities to give feedback. And in those settings, I think it's going to help us really take a quantum leap in terms of some outcomes of care.
Yeah,
This is a whole nother show right here,
I
Phil.
know that we're definitely going to have you back on for part two,
Mhm.
but I love that we were able to get this in. And, to kind of answer Jack's comment there about, clinicians and humans maybe being different things. I think, honestly, one of the reasons that I am critical of so many of my colleagues is because they function more like bots than human beings anymore. And one of the things I hope to see from AI is that, we can offload those bot functions that clinicians have been forced into back onto the machines and let the clinicians, be human again, and really be there to, like you said, interpret that data, translate that, and put it into human care.
That, that's exactly where we spend our time and we invest is what are those bot-like functions that we could safely do with AI to support the clinical role? And where do we need to surface that in the workflow and in the decision-making process? So, again, if I could gather all the information, do some comparisons, get a prediction, surface all of that in front of you when you came for when you're making rounds, you're in the workflow and you want that information, maybe I save you 3 to 5 minutes. That's critical time when I can do that for every patient. And so I think that's an exciting place, but we have to begin with, like you said, what are those problems that we're trying to solve with AI? I'd really love to, put the data into a machine learning model around metabolic health and outcomes. Could we put a 20-year history, a 10-year history? And where does that data sit? It makes me think about these things. Where is that data? Is it standardized? Could we get a team on this? Could we actually really look at what an algorithm would predict, the best metabolic health and outcomes to my earlier question? How do we prove that the science was here all along and we were just doing the wrong thing?
We got to have her back and
Look
talk
forward to it. Yeah, we're
hardcore
definitely going
AI
to
stuff.
have you
We
back
really
for
do.
this part of the discussion. And I think it was awesome that we got from senior care to AI and great stuff that you're doing. So for people that are interested in finding out more about what you do, again, the book is called Prepared. But where can they go to connect with you and find out more about what you're doing?
Yeah, so people can learn more about me right on my website, which is www.cherylfield.com. They can also connect with me on LinkedIn or Facebook. And it's, Cheryl Field, Senior Care Consultant. There's no mystery about how to find me. So would be happy to hear from anyone if you have, particular questions. I mean, you can grab a copy of Prepared. Actually, one of the things I really love to um, shout out is that it's available in large print, which I did intentionally so that seniors could actually read it and feel competent and in control. Because there's nothing worse than having eye strain and the really important information about yourself, you can't even read it. So it's available anywhere you get your books, and just toggle to other formats to find it in large print and give it as a gift to your parents. It is so empowering for them to feel a sense of control. It's like having a map, and you can see exactly the steps you need to take to go from where you are to where you want to get. I find that really helpful for me to have directions in those stages of life. So
I think
be
that's
happy
good.
for anyone to connect with me through those normal channels.
Yeah, that's terrific. I mean, my mom's 85 and runs most of us 20 and 25 and 30 years younger than her off our feet. Um, and I still think about these things. So
Yeah.
I'm going to get a copy of the book my own self. All right. She's Cheryl Field. All the contact information that is available for her. Her website, cherylfield.com. That's Cheryl, field, like standing out in the, um, is that's how you reach her. We'll provide all the other contact sources in the show notes. Thanks for joining us. This has been Stay Off My Operating Table with Dr. Philip Ovadia, and we will talk to you people next time.